I would like to introduce the second plenary speaker, Professor Bartha Maria Knoppers, and she is the distinguished James McGill Professor Emerita at McGill University. Many of you know Bartha, and I don't think she needs more introduction. What I would like also to say is that if you have any questions for the speakers, please save them so we can discuss them during the panel discussion. If you have, you can bring those up. Bartha?
Thank you, Petros. I'll begin. Can you put the slides up, please? All right. So what I want to start with is, what is public health ethics? And I used to teach law, I used to teach ethics and so on. It's always about the individual, privacy, autonomy, and very rarely in all the years of academia do you hear population health ethics or public health ethics. So what's different? It's that it's necessarily not about you. It's about all of us. It's about citizens in a given society. And they can be regrouped into populations, subpopulations. You can have screening programs, for instance, breast cancer screening programs for women stratified by age. You can have the traditional public health epidemic vaccination model, I call it. But very rarely do we talk about, as a society, particularly in countries such as Canada, with an ideal of universal health care. To have universal health care, you have to have a universal ethic, a public ethic, a communitarian, a population ethics. And to do that, the government needs to make sure that the citizens trust where the government is going to go in terms of health, investment in health, insurance of health, and activate the right to health, which I'll get to later. So it's the whole discussion we're going to have in the next few hours about genomic newborn screening is, in whose interest is this? Is it in our collective interest to find at-risk, asymptomatic, at-risk and asymptomatic children who can be treated, or where what their condition is actionable in the first years of their lives? And is it our responsibility from a public health point of view to undertake a newborn screening with that particular purpose, whether it's biochemical or genomic? So the values are different, the background's different, the context is different, and it's vocabulary that you don't see very often. It's also based on international human rights, and international human rights are not just individual rights. They belong to groups, to populations, to the collectivity. Now, the most famous one, of course, is self-determination and privacy in the medical context. And this will come up again because the more you find with genomic newborn screening, the more you have questions about how to activate or realize the right to make choices about your, in quotes, genomic future. But also privacy, because the data, once collected, is in the system. So the data is there to be used, it's there to be validated, it's there hopefully to be shared in projects like the Genome of Greece, which is part of the Genome of Europe project. So the privacy angle will come back following the newborn period during childhood, adolescence, and adulthood. Now, the best foundation for genomic newborn screening is the right to the highest attainable standard of health. Now, this is in every, it started in 1948 with the Universal Declaration on Human Rights, but it's also found in treaties and conventions that have been signed and ratified. And if a state signs and ratifies a convention or a treaty, or if, like the Universal Declaration, it enters into customary law, it is legally actionable. You can do something about it. You can ask your government, why haven't you done this? Or how come this happened? So the highest attainable is necessarily contextual. Doesn't mean that you have a right to be healthy. or to be born healthy, but the highest attainable state of health or standard of health is what is legally actionable by all citizens. And finally, the one right that very few people even know about at all is the right to science. And this is what they call the Cinderella right, because we only started waking up this right, this dormant right, about 20 years ago. And what does it mean, this right to science? It's in the Universal Declaration, but no one ever heard about it. Well, it's the freedom to conduct science, to conduct research. It's the freedom of citizens to participate in research. So you have a right, if you want to participate in research, to further science, scientific investigation. And what's interesting again about this right is that it also recognizes the right of scientists to attribution, to recognition for their invention. So it's sort of like intellectual property or copyright or whatever. You actually, if you've invented it, not just discovered it in nature, but invented or done something with it, that is also part of the right to science for which you have recognition. Now, my favorite subject, which was just alluded to by Dimitris, is that I've been teaching children in the law for probably about 25, 30 years. And it's an optional course. I might even have disappeared from a lot of campuses. Might not be such a hot topic anymore. But I maintain that someone has to notify society that children as citizens have their own rights, and they're not simply parental possessions till they reach majority. And their best interests are primary. This is from the International Convention on the Rights of the Child of 1989. They're primary. They're not to be taken into consideration. They are primary, their best interests. Again, you find the right to the highest attainable standard of health specifically in the children in the Convention on the Rights of the Child. And what's interesting here is that the article within the right to the highest attainable standard of health, the right to pre- and post-maternal care. It's very rare that you see a convention on a particular group inserting another group within the right. But this makes sense, especially for newborns, that their right before birth includes the right of the mother to pre- and post-maternal care. So when you're doing public health programs or population health programs, you have to have that trajectory in mind. And finally, the right to be heard. And with newborn screening, as the child becomes an adolescent and has intellectual capacity, then you obviously the right of the child to consent to keeping that data in their record and so on. So what does all this mean in terms of possible models moving forward? Well, there's 4 of them. The natural one is the medical care model. For me, newborn screening is the standard of care. It's a professional standard of care. Why are we arguing about it? If you can find an at-risk asymptomatic child and start treating that child immediately before the symptoms arise, that to me is pediatric care. I don't understand the objection just because it's genomic as opposed to biochemical. And so you could say that anyone going into the hospital giving birth expects the tests that are available and necessary to maximize the health of their future child to be undertaken. So most states have an implied consent model, and some states the nurse will ask, are you opting out of this genetic test? Now, Greece, as was mentioned by Petros, I think, right now is a mandatory screening model. Then there's the parents' patriae. This is exactly what it says, the power of the parent, which is the state, to ensure the protection of the rights and the health of the vulnerable, whether they're older people or babies. There's an obligation to look over and take care, which is why the state will sometimes intervene with parental decisions. You can think of parents whose 10-year-old needs a blood transfusion, but they're Jehovah's Witnesses. And they say, oh, our religion, we can't. And the state will intervene and use their parents' patriarchal power to make sure that child receives a transfusion. And then there's a rights-based model where the rights that I just mentioned are sort of weighed against each other and come up with a collective approach. And the public health research ethics framework, as I mentioned in the introduction, uses different approaches. What's the best part about newborn screening is that it's equitable. If it's a newborn screening public program, every baby will be tested, no matter where they are, poor, rich, urban, rural, and in that sense, every child has an equitable chance. Every child has an equitable chance of being found. And in some countries, even if they don't have the diets that go with, let's say, PKU or whatever, they will still use public health newborn screening. Why? Because in some countries, it's the only way that the child will actually be registered somewhere. Only way that you will know that that child exists is because of this program, even if they can't have all the benefits that come with it. So, in a way, if you communicate these goals, I think, and the prevention aspects, the life-saving aspects, the quality of life aspects, not just for the baby, but for the parents and the family and so on, if you can have prevention through detection, we haven't even gotten to treatment and everything else, just finding that child. For me, every child, every at-risk asymptomatic child has the right to be found as a child's right. Has nothing to do with us. It's their right to be found. And so we will struggle through the ups and downs and ins and outs of genomics and genetics and so on. But we have to keep that in mind as well. Detection with these methods of whole genome sequencing, certainly in the rare disease community, is the major breakthrough for finding more children with rare diseases who can be treated. Thank you.